Hi, and thank you for joining us for tonight's Musculoskeletal Health Australia webinar, Diagnosis and Management of Axial Spondyloarthritis, or the much easier to say, axSpA. My name is Helen Gents, and I'm a member of the MHA team. I would like to take this opportunity to acknowledge the traditional owners of the land on which we are all joining the webinar this evening. Musculoskeletal Health Australia is bringing this webinar to you from the lands of the Eastern Kulin Nation, and we pay our respects to the Burrawong and Burrarong and Wurundjeri peoples as the traditional owners and custodians of these lands. We acknowledge and uphold the traditional owners' continuing relationship to the land and waterways, and we pay our respects to their elders past, present, and emerging. If this evening's webinar raises any questions or concerns, please make sure you call the Musculoskeletal Health Australia Back Pain, Arthritis and Musculoskeletal Conditions, or as we like to call it, BAM, helpline on 1800 263 265 to speak with our highly qualified healthcare professionals. So for tonight's webinar, we are delving into an often complicated condition where people can live with symptoms like chronic back pain for many years before their diagnosis. We are extremely fortunate to be joined this evening by Dr. Lionel Schachna, Dr. Lionel Schachna, the Director of Rheumatology at the Austin Hospital here in Melbourne. So it's time to figuratively put our hands together and welcome Lionel.
Thanks very much, Helen, and welcome to everyone. I'll just share my slides, so just give me one moment. Okay, so I want to thank Musculoskeletal Health for inviting me to speak tonight about axial spondyloarthritis, or as Helen said, axSpA for short. We'll be talking a few aspects about the diagnosis and management. In the interest of time, we can't really cover everything, but I thought I'd find some little topics of interest to everyone. So what I'd like to do over the next 30 to 45 minutes is just address three questions. The first question is, what is axial SpA, and how is it different from the diagnosis of ankylosing spondylitis, or AS? The second thing I'd like to talk about is some common misconceptions about axial SpA, and then give you an update on the current management of the condition. So in order to answer the question about what axial SpA is, we need to understand and go through a few concepts, which I'll do in the next couple of minutes. The first thing we have to understand is the definition of inflammatory back pain. Then we have to understand how we define the diagnosis ankylosing spondylitis and the problem with that. And then finally, we understand that axial spondyloarthritis includes ankylosing spondylitis as well as other clinical presentations, which I'll explain in a moment. So with regards to inflammatory back pain, this is different to the common back pain that most people are going to get as they get older. This is pain that comes on at a relatively young age, and it's prolonged, so it's present for at least 3 months. The onset is fairly gradual, so it doesn't just come on overnight or with some bad movement. Morning stiffness is prolonged and significant. We would say that morning stiffness lasting more than 30 to 45 minutes is significant. Inflammatory back pain also improves with exercise, unlike mechanical back pain, which tends to be worse with activity. Now, the reason why I showed the newer definition is that there are two features that are shown here that are fairly specific for diagnosing inflammatory back pain. The first is awakening in the second half of the night because of pain. So people with active inflammatory back pain will often awaken at 2 or 3 in the morning with stiffness. And then if they're lucky, they can roll over and find a comfortable position and go back to sleep. But sometimes it can be more significant in that people need to get out of bed and stretch, and sometimes even take a hot shower to get relief. The other features that's fairly specific for inflammatory back pain is alternating buttock pain. So that's having buttock pain on the one side for a period of time, whether that's a day or two or a week or two, and then it switches to the other side and tends to go backwards and forwards. So these two features are fairly specific for inflammatory back pain, meaning that if you've got these features, it's very likely that the back pain is inflammatory and not mechanical. Not only can we identify inflammatory back pain, but there are scoring systems to assess how severe the back pain is. So one of them is the BASDAI form. For those of you who are on biologics, you'll be familiar with this form because each time an application goes into the PBS, we need to show that your inflammation level in the back has improved from baseline. So this is a questionnaire. Each of these lines is 10 centimeters in length, and the answer relates to how one has been over the last week. So the first question is about fatigue, then neck, back or hip pain, pain in peripheral joints, level of discomfort to any areas tended to touch or pressure. And then there are two questions about morning stiffness. One is about the severity of stiffness, and the other is the duration. And essentially, you take the average of where one marks the line. And if the average score is more than 4 centimeters across out of 10 centimeters, then one is considered as having active inflammatory back pain. Now, I mentioned before that we need to understand a little bit about the definition of ankylosing spondylitis. And although this definition goes back many years, it still holds today. So for someone to have ankylosing spondylitis, you need to have the clinical criteria. A is inflammatory back pain. B and C are measures of mobility. So you need to have at least one of those. And then you need to have the X-ray criteria. And if you have the clinical criteria and the X-ray criteria, then you have definite ankylosing spondylitis. So the X-ray criteria focus on the sacroiliac joints, which are just here in the pelvis. So the pelvic bone is made up of a number, well, two bones, the ilium and the sacrum. And where the sacrum joins the ilium in the back, that's the sacroiliac joint. And the sacroiliac joints are particularly involved in individuals with ankylosing spondylitis. This is an X-ray of a normal sacroiliac joint. So you can see on the side, there are these lines that come up vertically and then kind of move off to the side. So these what we would consider to be normal sacroiliac joints. There are various gradings of abnormalities from grade 1 to grade 4. And if you just have a look at, say, grade 2, for example, around the sacroiliac joint, there's this thickening of the bone or whiteness. The margin of the joint looks very indistinct. So this is an abnormal X-ray indicating sacroiliitis or inflammation of the sacroiliac joint. So the X-ray changes need to be either what we call grade 2, which is what we just had a look at now, and that has to be on both sides, or if it's the grading is more severe and it's just on one side, that's sufficient as well. Now, the problem is the X-rays usually take 10 years or more to become abnormal after one develops symptoms. So there was always this problem where we had patients who had fairly typical symptoms of ankylosing spondylitis, but the X-rays were normal, so therefore we couldn't call them ankylosing spondylitis. So there was a question for many years as to what to call label these patients as having. And so round about 2005, this concept of having two stages was developed. So there's on the right side, the radiographic stage, which means that people have symptoms and have got X-ray changes at the sacroiliac joint. But prior to that, most patients will have a non-radiographic stage where they've got back pain, but their X-rays are normal. As indicated on this figure, some of these patients will have MRI abnormalities, and it was really the development of MRI science in the 90s and early 2000s that allowed us to identify patients early on. So we've got these two forms of axial spondyloarthritis. There's the non-radiographic axial spondyloarthritis, and then there's the radiographic axial spondyloarthritis. So when we use the term axSpA, we include both groups. The radiographic stage is essentially the same as saying someone has ankylosing spondylitis. Then there are some definitions that were put together. These are mainly used in studies, but it allows us to consider how we would define the broader group of axial SpA and not limiting it to ankylosing spondylitis. So in order to have axial SpA, as it says here, you need to have sacroiliitis on imaging. But that asterisk means that the imaging study that needs to show the changes is not just the X-ray, but an MRI scan would do it as well. And this just shows you what the MRIs look like. These are the sacroiliac joints. And on the right side, all those white areas around the sacroiliac joints are areas of what we call bone edema or inflammation. So there is fluid and swelling in the bone, and the MRI detects that very nicely. The MRI of the spine will also detect bone edema, which tends to occur at the corner of the individual vertebra. So what we tend to see is that the white areas occur at the edges of the individual vertebral bodies. And on the right-hand side, you can see an X-ray of the spine, and you can see the development of these thin bony bridges between the individual vertebra. And they're what we call syndesmophytes. Now, that's what we want to try to prevent developing, because the more syndesmophytes you have, you can imagine the greater the immobility and stiffness of the spine. So a lot of the treatments that we use are to try to minimize the development of syndesmophytes and to maintain good spinal mobility. So to answer the question, what is axial SpA and how is it different from ankylosing spondylitis? Well, axial SpA encompasses ankylosing spondylitis, or the radiographic form of axial SpA, but also this other group of non-radiographic axial spondyloarthritis. I'd now like to address some of the common misconceptions about axial SpA, and we'll go through them in turn. The first is that women are unlikely to have axial SpA or ankylosing spondylitis. The next is that individuals who test negative for the HLA-B27 gene cannot have axial SpA. The third, I think we've already covered, that a normal X-ray for sacroiliac joints and spine rules out the diagnosis. And the fourth misconception is that markers of inflammation, namely ESR and CRP, are always going to be elevated when the condition flares up. With regards to women and axial SpA or ankylosing spondylitis, for those who are diagnosed with ankylosing spondylitis, about 1/3 are women. For those who have the early form, the non-radiographic form of axial SpA, women are as likely as men to have axial SpA, and that's something that's very important to recognise. There is still a longer delay in diagnosis for women, which is probably on the basis of a few things, including the observation that spinal mobility is generally greater in women, even when they're developing ankylosing spondylitis. And there's still some misconception that ankylosing spondylitis is a male condition. The second misconception I'd like to address is that those who test negative for HLA-B27 don't have axial SpA. HLA-B27 is a normal genetic variant that occurs in about 8% of the Caucasian population. If one has HLA-B27, only up to 5% will develop axial SpA, meaning that the vast majority will never have any spinal or other condition related to this gene that they've got. If, however, you've got HLA-B27 and the first-degree relatives, such as a parent or a sibling with axial SpA, then that risk goes up to about 20%. Now, still reassuringly, 80% will never develop axial spondyloarthritis. So that's something that I commonly discuss with individuals who are concerned about the risk of their children developing axial SpA if they've got the condition. The maximum risk is going to be about 20%. With regards to the prevalence of HLA-B27, so in ankylosing spondylitis, it's 85 to 90%. However, in those with early axial SpA, only 50% will have HLA-B27. We now know from my earlier discussion that this is a misconception that an X-ray, which is normal, rules out the diagnosis. So this is an MRI scan of a patient who has a normal X-ray, and the MRI scan clearly shows that there's inflammation at the sacroiliac joints. And finally, markers of inflammation are not always elevated when the condition flares. So the ESR and CRP, which are measures that the patients who are listening to this podcast video would be familiar with, it only goes up in 50% of people who have active disease. So in some people, it's a good measure of activity of axial SpA, but in many patients it's not. If the ESR or the CRP is very high, then that's very unusual for axial SpA, and one needs to think about other conditions. Now, the rest of the time, I'd like to talk about the management of axial SpA. The management involves a multidisciplinary team, which is facilitated by the rheumatologist, and that team will or may involve a physiotherapist, an occupational therapist, a psychologist, and the GP, of course, is a key player in looking after patients. There are a number of goals of treatment. We'd like to reduce the inflammatory activity, because if we know we can turn off the inflammation, then symptoms improve promptly. The other thing that happens if we turn off inflammation is that day-to-day functioning improves, and that it's much less likely that over time the syndesmophytes or bony bridges will develop and greatly limit spinal mobility. An important goal is try to work on spinal flexibility, and for most individuals, that's going to be mainly achieved through a exercise program, and there are good sources of information about exercises. All of the AS support websites have got videos or links to videos on what exercises are recommended. And I particularly recommend phone apps, because there are a number of very good and free phone apps which actually are very educational, but also give you a lot of information about recommended exercises and lifestyle changes. We'd like to support social participation, and there is an AS group in each state, and you'll be able to get their details from Musculoskeletal Australia, or just look them up online on your own. So, as I mention over and over again, optimal disease management is not just your medications, but the non-pharmacologic or the more general approaches are equally important in managing AS, even if one is responding well to their treatments given by their doctors. So again, this shows the importance of, right on the left-hand side, education, exercise, physiotherapy, rehabilitation if that's required, patient associations, self-help groups. After that, non-steroidal anti-inflammatories, so that's the anti-inflammatories such as Nurofen or Voltaren, just to name a couple. They have a key role to play in the management of the condition, and I'll speak about those in a moment. I mentioned, or it's mentioned here, sulfasalazine. Now, sulfasalazine is a medication that's commonly used in rheumatoid arthritis and arthritis related to psoriasis. The only time we use sulfasalazine and other similar medicines is if one has swollen, inflamed peripheral joints. They don't do anything for the spine. And same with steroid injections. Occasionally we will take fluid out of a joint and inject it with steroid. That's a short-term solution, which can be very helpful until other medications have a chance to kick in. I'll spend a bit of time talking about the BDMARDs, or the biologics, and the role they have to play. Surgery is very rarely required in individuals with ankylosing spondylitis. Even 20 to 30 years ago, it was not that uncommon to refer the severe cases to a surgeon, and that was essentially there was the patient who was so stooped over that they were staring at the ground and couldn't lift their head up to walk ahead of themselves. Fortunately, that's a fairly uncommon presentation these days, and the surgery was to straighten them up, although they never got any better mobility. So that is an option, but very uncommonly used these days. So a little bit about exercise and physiotherapy, supervised exercise programs, or individualized home-based exercise is better than no exercise at all. So whatever exercise program you're doing is going to be good. A supervised group physiotherapy program is better than home exercise, and part of that may be due to the motivation of being part of a group, and also perhaps better instruction in a supervised program as to how to perform the exercises. With regards to the anti-inflammatories, they're certainly very effective for the more milder cases. Many patients can manage quite well with regular exercise and anti-inflammatories as needed. However, there are potential side effects that one needs to keep in mind. Gastrointestinal, particularly acid reflux, and the risk of ulcers. If one has high blood pressure or is on blood pressure medication, that can be a problem. If there's some kidney damage, we will usually avoid the anti-inflammatories. And what we've recognized in the last 10 years or so, that the anti-inflammatories can increase the risk of cardiovascular events like heart attack and stroke. The risk of those things is fairly small, but in individuals who are older or have risk factors for those cardiovascular events, we will also tend to avoid the anti-inflammatories. When regular exercise and the anti-inflammatories are not managing the symptoms well enough, that's when we consider biologics. So these are the biologics that we have currently listed on the PBS for individuals with axial spondyloarthritis. Now, they're all listed for ankylosing spondylitis. The ones with the that are indicated there, the three medications are also available for non-radiographic axial spondyloarthritis. So we have TNF inhibitors. There are 5 of them available. There are IL-17 inhibitors, 2 of them available, and there's 1 JAK inhibitor. Some of you will be on biosimilars. So a biosimilar is a medicine that's very close, but not the identical copy of the original biological medicine. So they're very similar to generics, but the difference between a biosimilar and a generic is that a biosimilar or biologics need to be made on live cells. It's not something that you can just put the chemicals together to make up the medication. So the biosimilar is not going to be exactly the same, but they are rigorously tested to ensure that the benefits are similar to the so-called biooriginator and that there's no greater risk of side effects. So this is a diagram of the 5 TNF inhibitors that are available. Essentially what they do is that once they get into the bloodstream, they mop up the free TNF. Some of them will also bind to the TNF receptor and block that as well. So they essentially take TNF and remove it from the system. And because TNF, as well as IL-17, are such key players in causing the development and symptoms of axial SpA, that's why they are such effective treatments for the condition. The response is excellent, and the response occurs very quickly. So in the vast majority of cases, within 2 to 6 weeks, patients have a rapid improvement in their symptoms. And for most patients, they're fairly certain that it's working. Now, this is different to our use of biologics for other conditions, like in rheumatoid arthritis, where there's often a longer period of time before the effects become evident, and that it's not normally that dramatic to the patient. Not only do symptoms improve, but the MRI improves fairly quickly. So you can see on the before shot on the left-hand side, that whiteness around the sacroiliac joint, it's clearing by 6 weeks, and after 24 weeks, it's not there anymore. So that means that that bone edema or swelling of the bone has resolved over that period of time. The same will occur in the spine, as depicted here, where after 24 weeks, those areas of increased signal or marrow edema have resolved. The other thing that we now know after having used biologics, and this applies for all the biologics, not just the TNF inhibitors, but they are long-lasting. Now, probably 1 in 3 individuals will need to switch to an alternative biologic over time, but the benefit is generally going to be long-lasting. So with all this choice, how will you and your rheumatologist choose which biologic to go on? Now, they're all equally effective for back symptoms. So if one has just got spinal involvement and nothing else, then we will tend to still use the TNF inhibitors, given that they've been around the longest and that we have the most experience with them. There are some rheumatologists, however, who will try one of the other medicines for reasons that may suit that individual. But for most of us, we will be using a TNF inhibitor up front if the only symptoms someone has is back pain and stiffness. Among people with ankylosing spondylitis, about half will develop a so-called extra-articular manifestation. So these are a few of them mentioned here. So psoriasis is not that uncommon. So if one has significant psoriasis, we know that the IL-17 inhibitors work better than the TNF inhibitors, so we would probably favor them. In those who have inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, we generally favor a TNF inhibitor and sometimes a JAK inhibitor because it improves both symptoms. We will avoid an IL-17 inhibitor because there are reports of IL-17 inhibitors worsening inflammatory bowel disease. And if one has iritis or inflammation of the middle layer of the eye as a recurrent problem, we will tend to favor a TNF or IL-17, which are effective for this condition as well. Sometimes we make a decision based on risks for side effects. If one has had prior treatment for TB or some other infections, we might want to avoid TNF inhibitors. If one has a personal or family history of multiple sclerosis, we will generally avoid the TNF inhibitors. And for those who are older or have risk factors for heart disease, we tend to avoid the JAK inhibitors. Just some general rules about biologics. If you have a serious infection, the advice is to discontinue biologics and then recommence once the infection has resolved. One should avoid live vaccines, such as yellow fever or oral typhoid vaccine. One should be sun safe and use sunscreen as appropriate because of the greater risk of skin cancers. And if one has got elective surgery coming up, we generally say to withhold treatment for one treatment cycle. So that means that if you're administering your injection once a fortnight, then you would hold off for 2 weeks before surgery and generally restart 1 or 2 weeks after surgery. I'd like to finish off by discussing the criteria for obtaining the biologics among individuals with axial SpA. So in order to be able to access it through the PBS, there needs to be some abnormality on imaging, either X-ray or abnormalities, or if the X-rays are normal, MRI findings of active inflammation. So even though obviously the symptoms and the clinical presentation is the most important thing, if one doesn't have any imaging abnormalities, then the PBS criteria don't apply. So if one needs to go into a biologic, it won't be through the PBS. So you have these changes. Then you have at least 2 of the following: inflammatory back pain and decreased mobility. And then finally, you need to have tried for at least 3 months an exercise program and at least 2 anti-inflammatories. And the PBS define an inadequate response to this as the BASDI questionnaire greater than 4. So that's the questionnaire I showed you earlier. And either an ESR above 25 or a CRP above 10. So they need to be elevated. So that's the BASDI again, just to remind you what that is. And then once you're on treatment, you need to be reassessed after 12 weeks by your rheumatologist. And that questionnaire has to improve by 2 points. And the inflammation levels need to either be back in the normal range or drop by at least 20%. And there's a reassessment every 6 months, and we need to demonstrate that the BASDI has dropped is still at 2 points less than the baseline, and the inflammatory markers are less than before you started treatment. And that's all I've got. So happy to take any questions.
Thanks, Lionel. We've had a fair few questions through the chat. I'll answer a simple one that Jeanette asked. Yes, this presentation will be, it has been recorded and it will be available on demand, and we will send a notification out once that's ready to go. So I'll start with one of the questions relating to your slides, Lionel. One of our attendees asked if you could explain the grade 4 example you gave. So I'm assuming from that question, they're wanting to know what happens if you see someone with that grade 4? What are you looking for there, and what sort of steps would you start taking if you saw a patient with that grade 4 example you put up?
Okay, I guess that gets to the question of what do the X-rays at the sacroiliac joints mean. Now, grade 4 is when the X-ray is fused. Now, because the sacroiliac joints have very little movement normally, it doesn't really matter if the X-ray shows fusion. It doesn't change anything at all in terms of one's function or mobility. And in fact, sometimes the pain will improve once the joints become fused. The only time where, at least theoretically, there may be a problem is during labor and childbirth, where the pelvis may not widen as much as it would if it wasn't fused. But at the end of the day, we don't do anything different if we see fused X-rays. And my sense is that once one starts to develop X-ray changes, it will naturally progress over time, but it's got no relationship at all to one's symptoms.
Okay, great. This was an interesting question, and around when you're getting a referral from your GP to a specialist, to a rheumatologist. As a consumer, is there any way that, or any place that you can go to get a sense of whether the rheumatologist is actually accepting new patients? Because the comment was, what's happened is, a GP will refer someone to a rheumatologist, and then they'll ring the rheumatologist to make an appointment, and the rheumatologist isn't actually taking on new patients. So is there anything through that you're aware of through the ARA or anything like that that could assist patients with knowing which rheumatologists in their area are actually taking on patients, or is it a bit of potluck like that?
I guess it's a general question unrelated to the topic.
Yes.
But yeah, it is a problem. I'm not sure if someone's referring to my rooms, but if you ring up my secretary, that's what we tell patients. My problem was that I took on a lot of extra patients during COVID, and then and a lot of them were done by telemedicine. So it was in some ways a bit easier to take on more patients, but then now they've all come back. So it's difficult. There is unfortunately a shortage in Australia of rheumatologists. Some areas, regions, there's more of a shortage. I'm not aware that there's any website, or the ARA keeps track of people who are not accepting new patients. Sometimes that's only for a short period of time. I know in my practice, even though I generally say I'm not accepting new patients, patients we still offer for the referrals to come in and be triaged, and the ones that do really need to be seen as soon as possible, I will make time to see them. And I've got a couple of other rheumatologists who work with me, and we try to fit them in. But I'm not. Yeah, it's a very difficult problem. We are, as a rheumatology community, trying to deal with that by training up more rheumatologists. The number of training spots has doubled in the last 5 years, meaning there'll be more rheumatologists coming through over the next few years. But
I can assure you, Lionel, it wasn't a reference to you. The questioner just made a note. They're in Perth, so they're certainly not referring.
I'm just like a prime example.
All right, we'll
yeah.
get back to asking some questions about your presentation. One was, you did mention some phone apps in your presentations, or apps that people could use. Are there any that jump out that you could mention, or perhaps if you could provide us with some links to them, we could add them when we're putting the presentation out, so people have an awareness of what these apps are and where they could go looking for them?
Yeah. Well, the simplest way to find them obviously is to just put in your search ankylosing spondylitis. But the two that I think are particularly good are the NAS and ASS, the National AS Support Group from the UK, who have an excellent website, but they also have a very good app. And then there's also a app that I think is called Little I ankylosing spondylitis, which is an Australian-based app. There is a paid version and a free version. The free version is excellent as well. So there may well be, so I haven't looked recently at the app stores, but they're the two that I'm certainly aware of as being very good.
Okay, fantastic. One of the questions that has been raised is, what's the best diet, do you think, to follow if you've been diagnosed with axSpA? Is there a particular type of diet, or is it just the general healthy eating diet? Are there foods that have been shown to be better for you, not better for you?
That's always a question that comes up. And there's nothing particularly different about ankylosing spondylitis compared to other inflammatory rheumatic disorders. There was a trend once upon a time to consider starch-free diets, which turned out to be very restrictive based on science that turned out not to be all that valid, but there are still some believers in that. But the general consensus among rheumatologists and experts in AS is that that probably doesn't make any difference to one's symptoms or the eventual outcomes. But more and more we're aware of things like Mediterranean diets, vegetable-based diets, avoiding fatty foods and high sugar. So a good general anti-inflammatory diet is recommended, although I must say that the evidence supporting that is not all that strong. Now, that's probably because it's very hard to do studies of diet and its effects upon individuals. But there's certainly going to be something to it. We also recognize that the microbiome, the natural gut flora, has a lot to do with inflammatory conditions and in particular spondyloarthritis. So if you can keep your gut flora healthy and well balanced, that can only be helpful.
Excellent. Now, Petra asked the question, how, and it's a fairly broad question, Lionel, so maybe it's more from your individual perspective, but what's the use of biologics in terms of treating axSpA? Is it that the majority of patients are on biologics, or can you not make a call? It's basically depends on the individual and the progression of the disease that they've got.
Yeah, so at the end of the day, probably 2/3 of people with spondyloarthritis will end up on a biologic and require a biologic. Now, there are certainly a fair number of patients who I've followed for 10, 20 years who have done just fine with exercise and using anti-inflammatories. But that's not actually the majority of people, but it's an individualized decision about when to consider biologics. Early on with the biologics, there was a lot of concern about potential risks, particularly cancer risks, heart disease. Those turned out not to pan out over the years. And, early on people wanted to know how long have we been using these medicines? And we said 2, 3, 4, 5 years. And for a lot of people, that was concerning. But the biologics have been available since the late 90s. So we've got, almost 25 years of experience in Australia with the use of biologics. And the reassuring thing is that there've been no new risks or signals that have come out in the last, I'd say, the last 15 years. So whatever side effects we're aware of now, we were aware of early on. It's not like we've kept using the biologics longer and longer, and then there are new side effects that are appearing. So one can certainly be very much reassured by that. The other thing is people have to recognise, even though there is a process to get on it through the PBS, it's just like any other medicine. So the day you say you don't want to go on or stay on it, you can stop it, just like any other medication. And a lot of people will actually now think about cutting back the number of injections they do, and some people get away with it. So, for example, you may be on adalimumab every 2 weeks, and then you extend it out to every 4 weeks. Most people can't come off treatment, not because it's dangerous to. They just can't come off treatment because as soon as they come off, their symptoms come back to the way they were before, and they want to go back onto treatment. So in our experience is that when we start someone on a biologic, 95% of people are still on the biologic 10 years later. 5% have stopped, half of them because of side effects, which is like 2 to 3%, and half of them because it didn't work.
Okay, fantastic. Now, here's an interesting one from Annette. She's referring to her experience where she's had a number of MRIs, and the first MRI, a specialist looks at it and says, you've got sorry, how do you say that?
Yeah.
Yes.
Okay.
And then she goes and gets another MRI, and a different specialist says, no, you've got something else. When you're a patient and you're getting multiple different diagnoses like that, is it worthwhile? I'm assuming from what Annette's written that she's seeing rheumatologists. How do those variations in diagnosis play out, and what should the consumer do?
So I think that those situations occur because the MRI is an inexact measure of disease activity. And there may well be MRI findings that are unrelated to one's back pain. So, for example, we know that after vigorous exercise, there is swelling or marrow edema in the sacroiliac joints. We know that after childbirth, for a number of months, the MRIs will be abnormal. So it can be challenging, can be difficult. So just because one's got an abnormal MRI doesn't mean that one has got axial SpA. So that's where the problem may occur. So there may well be one rheumatologist who looks at it and says, well, the changes are pretty minimal. And this story really doesn't sound to me like axial SpA. And they will tell the patient, I don't think you've got axial SpA, but the sensible thing to do would be come back in 6 months and we'll reassess things. But that same person may have gone to another rheumatologist who said, well, I can see those MRI findings, and to me, they look significant. And I think your story is pretty good for the condition. And then they're told they have axial SpA. So it's unfortunate that the MRI abnormalities are not specific for axial SpA. and can be normal variants. So that's where I think that probably in that scenario has played out, the
Excellent.
interpretation of the MRI.
Fantastic. Thank you. Now, this is a really good question because I found this part of your presentation really interesting. And another Helen who's online said, what's being done to get the message out to other doctors, and let's start with GPs and go from there, that axSpA actually does affect women, given there seemed to be this narrative that it was only a disease that affected males for a period of time. So what's being done there to sort of make GPs and that aware that it does affect women?
Yeah, I mean, that's not anything new. That's something that we were doing back in the early 2000s when the TNF inhibitors became available. So the old textbooks, like the very old textbooks from last century, suggested that the male to female ratio was 9-1, that 10% of individuals who were affected were women. But then, when the TNF inhibitors became available in, 2003, that's when there was a big push to educate the GPs about, women being affected by AS. So it's not anything that's new. The drug companies had their own interests in identifying as many patients in the community with undiagnosed ankylosing spondylitis. So they funded a lot of those education events for GPs. And any GP who reads any review now in a GP journal, that will be something that's highlighted. So we've been doing that for quite some time now.
Excellent. Now, I'm conscious of the timeline also. I'm going to wrap up with this last question for you. How important is it to continue with exercise? And there's two parts to this. When you're on a biologic is a question that Annie asked, how important is it to continue with exercise? And then an add-on to that is, how do you encourage a patient to continue to exercise or do some sort of exercise or movement when they're in chronic pain with their back?
Often it's the other way. So with the chronic pain with their back, the exercise is, if one does have ankylosing spondylitis, axial SpA, they're going to feel better when they exercise. But you're right, it can be difficult, particularly in patients who have a later stage of ankylosing spondylitis, to maintain a good exercise regimen. So, the physio, the group sessions, hopefully the benefit that the patient themselves sees will encourage them to continue with that. But the problem that Annie's alluding to is when one feels better, you think, I'll just take the biologics and stop exercising because you don't need to anymore to control your symptoms. But that's not what you want to do, because regular exercise will enhance the benefit of the biologics, and it will also maintain greater flexibility, and you'll have a greater ability to do things day to day. So the exercise really is from the time of diagnosis to all the way to the biologics. Exercise regimen is critical, and one shouldn't drop it even if you're feeling well on the biologics.
Wonderful. Well, Lionel, thank you so much for an absolutely fascinating presentation. As I'm sure you can see, some of the comments are how much the attendees have gotten out of this evening. So on behalf of Musculoskeletal Health Australia and all our attendees this evening. Thank you so much for giving up your very precious time and giving such a wonderful presentation this evening. And thank you everyone for joining us. We will let you know when the recording is available to watch on demand. So have a great night. Thank you once again, Lionel.
Thank you. Have a good night, everyone.